Well, here we are. We're recording another episode. What is this we're talking about today, Renee?
Well, you just got yourself back from another trip to North Dakota, and it sounds to me like you might have picked up a little something along your journey.
Oh, that's my rant today. It's a summer cold, and there's
Oh,
nothing worse than going through. I counted. I was in eight airports last week to get to this conference between another project and that, and I picked up something along the way, and I'm struggling, but I'm hanging in there. I've got tea with honey in it, and just trying to get through my day.
oh yeah, 8 airports. Yeah, you can come up with all kinds of diseases in 8 airports. Wow, that's a lot of airports. I had a dude I was sitting on a plane last week because I too was traveling. When you were traveling, I went a
Mhm.
different direction, and I had a guy next to me that just kept coughing, and the whole time I'm like, oh my gosh, what is he trying to give me and the rest of the airplane? Because he just kept it up, and he was gonna get a sharp elbow to the ribs if he kept continuing because he wasn't in a mask or anything. Half the time he was kind of asleep, so I'm not sure he was coughing on purpose. But dang, so I had the same thoughts last week, but I apparently have come out unscathed, unlike you, who sound a little froggy this morning. Well, today, everybody, we're going to dive into the Dakota Conference on Rural Health. It's got a new name this year, and Jason and I have been to this one before. And so we're going to talk about like what's new this year, what's going on. It's always a good time to reconnect with our folks in North Dakota. They have a big new state hospital coming out next year that we really would like to get up there for the ribbon cutting since we've had some work involved in that. It would be really kind of cool.
Mhm.
So this year you went up and talked about that. So to kick us off, the Rural Dakota Conference. I know when you first got there, you sent me a picture and it was kind of slow, a slow start to that conference. So I don't know if people were on a different time zone than you or what was going on.
There's sometimes you go to a conference and when you walk in, something just feels a little bit off. We've all been
Okay.
to that conference, right? Where you
Yeah.
kind of you get there and you walk
Yeah.
in. Yeah, literally when the first keynote started, the room was almost empty. And part of it, I think, was the room setup was way too big for the number of people
Oh,
who were going to
yeah.
be in attendance there. And so it
Mhm.
perceptually looked empty just because it was such a massive room. But I sent you a picture and it was all the empty tables at the front. When there's
Yeah.
3 rows of empty tables at the front, like, you know,
Wow.
seating for 100 that's empty and everyone's in the back. It's tough for the keynoter too. I mean, can you imagine? I mean, we've been in some of those
Yeah.
rooms and it just makes it hard for everybody, Renee.
Yeah, wasn't there? There's a rumor, and maybe this is a rumor. It could be true, but there's like somebody who paid to buy like, all the seats out of the front of somebody's concert so that when they showed up, they had no one to sing to in those front rows. It was like a beef between two singers. It's one of those lore stories out and about.
Yeah.
But like I could imagine it has to be tough because you just go talk to nobody. I've had to do that before, and you can't
Yep.
you can't pretend like that's a thing and you have to keep going and deliver because sometimes you have just the right people in the room and that's what matters, but it is kind
Right.
of rough. I was at the opposite. I was in a conference in Arizona at the same time, and ours was standing room only. They had
Yeah.
not set up enough tables. And so people were literally sitting along the walls and just kept coming in and standing in the back. And I don't know and they're paid people to be there. So I don't think that was correct either because I mean, they oversold and people are hanging out the hallway. And so then the rest of the day, people didn't come into all the rooms because there just really wasn't enough space. So I think I've gone both directions, and I don't know if one's better than the other. From the keynotes perspective, standing room
Yeah.
only is a great thing.
Yeah.
But when you've paid for it as a conference attender, that's kind of dumb because you have to eat food. And where in the heck are you going to eat it if you
Right.
can't find a chair? It's just kind of rude. So I've gone both
Right.
ways. So
Yeah. So
you also wanted to chat about award banquets. These are my faves. So I'm very excited to hear what you have to say about this because
well,
I have
I
some
thought it'd be
thoughts.
just something we should talk about for a
We
minute
should talk
because,
about it.
in the same sense, these tables that were empty, no one came for lunch either. And so there were probably 300 salads that no one ate,
Oh,
that were
jeez.
sat out at the tables.
Oh,
People are coming around going, "Why don't you take that salad and that salad? You can have all the salads because there were, I'm like, no, I'm good. I don't need another salad or another cheesecake, but thanks for the offer anyway."
you can have all the salad. Yep.
Yeah,
And you've been to those though when all the food runs out. You've been to one of those
right,
too. And you're
right.
you're the speaker and you can't get out of your room because you're following up talking to
Yep,
people and you're the right before lunch speaker. By the time you get to the line, there's nothing to eat. You've been
right,
there. I've been there
right.
too. So it's
Yep.
like conferencing, we have a podcast for all of you out there listening about conferencing, and we really to do another one just about the logistics because we really understand to do it right, don't do it right because we've done all of it, and it's just kind of a
And
fun situation. But
and
let's dive into award banquets
no,
because
I got one more
you got
because
more.
sometimes the schedule doesn't allow for time to network in between
Oh,
sessions where one session ends, the other one begins, which how
yeah,
does people get from one to the other? And then sometimes they allow 15 minutes, depending on which day it was. I could go on and on, but
yeah.
I think that it all just kind of is
Yeah,
how things
we
end
had
up,
one.
right?
We had one when we recorded this last week, but talking about the Arizona one on Access, which is their Medicaid program, AHCCCS, which does not spell access, but they think it does.
Uh-huh.
Anyway, they got done too early before the blessing and the opening was too early, so they got
Yeah.
extra time, and boy, they used every last minute. So it's a good thing they got that extra time because they would have run over and we would have been crashed into the rest of the day. So maybe they knew that and that's why they cut the opening short. But you can see it go both ways. You and I have
Yep.
been there. The last
Yep.
conference you and I did, I can't remember which state we were in, but where they called us up 30 minutes early or something because we happened to be in the crowd. It was like Wyoming, I think. And they were done early.
Oh,
So they're like,
right.
oh, the next speakers are here. Come on up. And we're like, what?
Right.
Like, good thing we're
Right.
sitting there in the room because, like, what are they going to do for that many minutes if you and I
Yep.
weren't ready to just be like, sure,
Oh,
we'll come early? It's
yeah.
just kind of crazy all over. So can now I talk about award banquets? I've tried a couple times. That's my
Oh,
favorite.
yeah. And I thought we did. I thought we were done with that. Oh, go on.
No,
Oh,
award banquets.
sorry.
Okay, so here's my favorite part. I really do love this so much. When you're a little clique as the board
Oh,
president, vice president, all those people, and you give awards to all your friends
yes.
while telling inside jokes the whole time that only you and your little clique friends understand, and 500 people have to watch it go down while we
Hmm.
eat bad chicken with the
Yes.
sauce. What are we
Yes.
doing, folks? What are we doing? And then if the prizes, remember that place we were, we won't name it, but they gave out baseball bats as the
Oh,
prize?
that was, yes.
How do you get that home, folks?
Right.
Everybody flew to where you are. So are there thoughts about this? How about those baskets that you win on prizes that are bigger than your house and you're supposed to somehow take that home with you and then you don't want to offend people, but what are you going to do with it? Do you know how many of those get left in hotel rooms for the staff? So
Yes.
many. Just so many because you can only take what you want. I mean, we think about Brent's yoga package, right? You told me all
Right.
about that. Not all that made it back. He probably gifted that to who
Yeah.
knows who in a hotel, right? We've gifted flowers to people in hotels. I've gifted,
Oh, yeah.
I mean, come on. So a little gift card goes a long way. At least it travels, you know.
Hmm.
If it's someplace that is even in your state. I've gotten gift cards before to restaurants that aren't even where I go. I'm not even there. So I'm like, I'll take it home with me, but there's not one of those for 3,000 miles. I'd have to carry it on vacation the next time I travel to wherever. I don't know. I just think there should be a little more thought to lots of all that. That's just not cute.
It's
Just not
hard.
cute.
I mean, it's great when we can celebrate success and provide those. Sometimes
Yeah.
it's just hard because the story isn't told in a way that is really helpful to everyone that's in the audience. And so,
No,
I think
no.
there's not always enough thought about how do we do this in a way that some people in the audience know the person very well, but most of the audience may not. They may know of the person just because they're from the same state or same region. But are they really accentuating the good work that they're trying to promote? And I think sometimes they miss the mark.
100%. On the ones that are done well, though, I mean, it's really moving. Their crowds like to tears and they're thinking
Yep,
about how monumental their work was and
yep,
how well they've done. So I've seen awesome ones, but I've seen so many not ones that have just missed the whole thing. So sometimes, I mean, I'm one that skipped those lunches sometimes. I'm just like, I just can't take another inside joke afternoon. I'm gonna go get different food and
right,
just be move on about
right.
my day. All right, so at this conference, what was new or different? Something you wanted to highlight that you thought about that you heard this time around?
Well, I was going to kind of continue our theme. If, sometimes we go to sessions, and if it sounds too good to be true, maybe it is too good to be true. Renee, have
Uh-oh.
you ever found yourself in a session, you read it, and you're like, I'm going to go to that just because I'm a little skeptical
Yep.
that these things can all happen the
Yep.
way they say they do. And then you get there and you sit through it, and you're like, wow, that must be amazing. I would like to know more.
Yep.
Have you been in this situation, Renee?
Yep. And I have
Because
learned sometimes that it is a pitch being made for a pilot that isn't even approved yet. Have you ever done one of those where you're
I,
like, this, we
yes,
just submitted this as our proposal for the whatever. So it sounds
yes.
amazing, but it actually doesn't exist in real life. And
Be-
there's no guarantee they even got that proposal granted.
Because
So then you don't even know the reality of that.
because
Yes.
when they bring the medical director in to do the pitch for
Ooh.
credibility, and they
Ooh.
say they've done something that actually
Yes.
hasn't been implemented yet. And
Yes.
you're like, I'd like to learn more about how they do said thing. And I stick around and go up and ask a few questions, and they give me the pitch. And I'm like, no, I'm not from here. I'm just interested how you engage with XYZ population. And they're like, we've got it all figured out.
Well, if you, for those that are new to the podcast or maybe don't remember, when I used the term stars on a map,
Yeah,
it came from the state of North Dakota.
did.
Originally, back now over 14 years ago, 15 years
Yep,
ago, where they decided they had a mobile crisis search system, I think.
yep.
And supposedly all the stars on the map were the locations where it existed, except it didn't. And it was one of those where I got the pitch, I got the thoughts. I heard the medical director tell me the things. And when I went to where the places were on the map that had stars, it did not. So it was more of a vision casting of where they hoped it would be, but presented it as a done deal. And so I use that a lot analogy as stars on a map because that happens very often in HHSs across our country and at the federal level where they put it on a vision board of where they think these services are going to be. And when you do it that way, it doesn't true up to reality of what is even there. Some of those stars on a map were in locations where there were no providers. Some of those stars were in locations where it just couldn't be. Like some of it didn't even have, maybe teleconnectivity to even have mobile, even to make crisis calls because it's very rural in some of those places. So you probably didn't even have access or coverage. I mean, just pretty wild. And so it's weird to me that they do that to the general public buys it. It's people like us who know what we're talking about that are like, hey, wait a second. Where is that you've got on this map? Or what is that you just said? How do you do that? And they're like, we have a plan. Yeah,
Yep.
but they don't tell you that it's a vision or whatever. They try to tell you like it's a real deal. So you must have run into one of those in North Dakota. You want to talk about it?
I did. And I mean, I will say, and this kind of rolls us into data a little bit. One of the things that North Dakota has done exceptionally is what's called the Rough Rider Network. You remember the Rough
Mm.
Rider Network from, they started this a decade ago where they pulled together all of their hospitals or a majority of them, right, to start
Yeah.
with. And they started investing in technology and IT. All of their hospitals share Epic. You can have information flow across the entire healthcare system. And North Dakota was able to kind of firewall off all of their providers and do this in a way where they could leverage funding and be very efficient at it. And so we do have to give North Dakota props for, as a state, and because they're a small state, they could actually do this in a way that was meaningful. And so that's really great, right? And
Yeah.
so the presentation I went to was taking that to the next level of providing care coordination and connecting to all the other community resources. So we think about behavioral health providers, food insecurity, the things we talk about and do a lot of, creating clinical flows to connect communities together around the healthcare provider. Now, that sounds really good, doesn't it, Renee? If
It
all of
does.
that could be done with a technology solution and
Mm,
artificial intelligence to predict when
mm,
someone was going to need something, wouldn't that be a
mm,
game changer? If that
mm.
could be done in rural Minot, North Dakota, would that be pretty amazing?
Let's add the robot to pass the message, and you've got yourself a thing.
I
I mean, they
know.
know
And
a lot
so,
about aliens up there, so you could pull it off
well,
probably. You might
and
be.
so I was kind of, I was thinking about,
So I do
they,
have a crazy question for you. Do they have a
yeah.
dashboard out of all this shared IT that actually pulls in more real-time data than some? Because if you can share all that IT, you would think that there'd be some more real-time numbers coming in that make a little more sense in their state, or have they not really got that part down yet?
Well, no one talked about that.
Oh
So,
boy.
I would think that that would have been
Because
promoted.
that's usually the excuse for why you don't have that, right? Is that we don't have
Right.
shared IT. So therefore we don't have good quality
I,
shared data. So if you've
I,
got the good quality
yeah.
IT, that should then link to good data,
I,
but you're saying maybe
I
not so
I
much,
think they probably do have more than we think of because we think about, how fragmented care is. If there's continuously coordinated care, which is what they're striving for, you're going
right?
to be able to measure that and show outcomes and have data around that. I will point out, one of the things they talked about was 5% of patients drive over half of the total cost. And we talk about this a lot,
Yeah,
right? You have a very small percentage of folks who are driving the biggest bill within our healthcare system. And so
right.
I completely support these types of initiatives because this is what we have to do. That 5% generally has an underlying SUD or behavioral health condition, comorbid condition that relates to it, right? So that's right in our lane. And so I really love to talk about and figure out how are we folding behavioral healthcare providers into this healthcare continuum of care. When we talk about continuously coordinated, I don't know how you do that if you're not working with peer recovery coaches, substance abuse providers, FQHCs, CMHCs, all of the different CCBHCs. We could go through all the acronyms of those folks who are providers of keeping those high-end patient populations stabilized.
Yeah. So one of the things we should do a shout out for North Dakota, and this was one of our recommendations from a million years ago, is they now have a CCBHC.
They
They
do.
finally were awarded one
Yep.
with their state agency was awarded it, so they had to make the changes at the state agency to pull that off. And you and I wrote that report 21,
hmm
22. And so
So,
it's cool to see something come to fruition that we had talked about then, because that was a big piece of what was the gap in their system. And so for them to be able to get that financing finally, it was just announced within the last month that they
the
finally now have one. And they were one of the stars on the map without one in the state.
and it's important people understand though that the treatment system is actually owned and operated by the state,
Right.
which is very interesting,
Right.
and kind of scary sometimes, because the state is not always the most efficient entity to manage healthcare, right? As
Yeah.
the provider and the payer and doing all of it
Yeah.
together across the entire continuum. It's a
Right.
little concerning in places.
Yeah, this is the state that had the lifetime case management. If you've ever heard me use
Right.
that term before, case management for life, where the roles were filled with people who once upon a time used case management. So the people that had been there the longest had a load of people on their case management roster, but only maybe 5 to 10 people would be active, but they were full. And other people that are newer were getting all the active cases. So they'd have the same number of cases, but all active cases, when these others got to just sit back with the, well, just in case they ever might need case management again, I have to stay available. And when you call it case management for life as a consultant, it raises some eyebrows and it gets some shackles going up. And all of a sudden, people were like, what? And so that has been a massive change also made since we were there. And it wasn't 100% necessary. I mean, I'm not even sure people weren't dead that were on those case management
Yeah.
roles. I mean, because nobody ever looked. So it's
Right.
like, that's insane. So that was keeping people from the system because they, quote, had no openings.
Right.
Well, in a state like North Dakota, you don't have like the widest dearth of resources, so you've got to use what you got, and you can't just have fake people on accounts clogging up
hmm
the system. So they clean that up pretty quick. But you're right, there are some pieces because those are some of those empty buildings we walked through, nobody there, all the stuff. So it'll be interesting to see. But they had to make some changes. I mean, I haven't read their plan. I want to go back and read it because they've had to make some changes for them to even be granted that because
Yeah.
it wasn't going to work the way it was structured originally. So they've had to make changes in how they do it as a state to even get
Yep.
the designation. So it'll be interesting to kind of circle back on that. Maybe we should talk about that in the future. All right. So I'm sure that we had more conversations about people going to emergency departments and critical access hospitals and some of that stuff. Is that's still going on, I'm guessing, in North Dakota?
Well, yeah. So after I learned about there was this tool and everything was continuously coordinated, I'm like, well, EDs must be purring along perfectly because I was just
Must be.
told that there's standardized clinical workflows that are able to be accessed across every hospital
Right.
and that all providers use this. And so I'm like, well, then if someone goes to the ED, they must just walk out with everything they need and be connected because I was just told in this session that that's how it works. all the time, every time. And so I go to the next session and I'm like, well, this will be great. And it was about emergency department transfers and what the Flex program is doing. You know, we do work for Flex programs in other states. And I'm like, this is great. We're doing an emergency room transfer project in another state. This is going to be about emergency transfers, you know, specifically about patient safety, care coordination, patient experience in the emergency department. All four areas we work in hospitals as we think about transferring patients with mental health and SUD conditions to community providers. Maybe I'll learn something, but because they've got it figured out. They have pathways and flows. And guess what, Renee? It's not figured
Stars on the
out.
map.
They've been
Stars
working
on
on
the map.
this project for years as part of the Flex program, and they've just now got to a point where, guess what? That in three hospitals, they're actually, this is the eight elements that they should have before a patient is transferred out of the ED. It should have their medications listed, allergies and reactions, mental status and orientation, reason for transfer, a plan of care, tests and procedures the ED performed, and those results. They finally, after working the last year, got three hospitals to do that almost 100% of the time, which is great.
Wow. Wow.
But
And there's nothing wrong with this, folks. If you're at a conference and you're telling the truth that this is your plan, your pilot, your goal, your direction you're moving, but when you couch it that it's a done deal and you got this hero program that does all the things, people like us can see right through it. And what's really sad is so do all your employees. They
right,
know. And so then it's just like they don't, it destroys trust with you as an employer, as a leader, when you're telling them, we've got this all figured out. And they're doing the day to day going, wait, why did I just catch this person who didn't have their meds? Why did I catch this person who they don't even know the results of their tests? We're going to have to redo the tests because they didn't get the results. And so then it just waters down all of that. And when HHS in any state is the lead of that, it makes everybody below them go, that's not true. And then we don't believe them. And it just erodes trust, it erodes the vision, it erodes a lot of things. And it all depends on how you couch it because yes, this is an awesome goal. And the fact that you have three hospitals that are close, that's pretty cool. I told
right.
you the podcast we just recorded before this, I watched a whole data slide on savings for somebody for one person. It was
Yep.
in the tiny print at the bottom. They couched that as the show of the success of a program for one dude. And then they
Right.
pretend like that I'm supposed to figure out that that means it's a success for all and we're going to
Mm.
save all this money. It was one guy. Like, why would you do that? Right. So I know they're trying to tell a story, but those of us in the audience who catch that are like, wait, that's just one guy. There's 99 more that aren't going to have that same story. So that means that's not going to be true.
And, you know, I think it's important we recognize how difficult it is to change all the different aspects and parts and pieces connected to that larger system. It's
Yeah.
much easier to go into this established network of hospitals who have already coordinated care and have the same policies and procedures, really, because they've had to standardize. But
Yeah.
they've yet to invite in all of those small providers in rural communities. And we talk about this rural all the time is you have to engage with those folks. You just can't slap them into your clinical pathway and then hand them the pathway and say, here's what your role is, do it. Because they don't understand their role. No one sat down and explained it with them. And so that's then just accentuates missed handoffs because they don't even understand what their role and purpose is anymore. And we see this happen over and over again, where it's just, this is how it's going to be. But no one sat down and took the time to figure it out and make it work. It can work, but it has to be established. There has to be buy-in. There has to be guardrails in place. And there has to be understanding of all of the partners across the continuum of care.
Yeah. And this isn't just hospitals. This happens in administration and places
Oh,
across the country. I mean, we're in a similar spot in government where we're a small agency and the clinical pathway, if you will, the path, the progress, the SOP that I'm supposed to follow in any given situation is built on big departments like corrections or HHS or, whatever. And then we have, 10, 11 people. And then it comes down to us and we're supposed to figure out how we fit into that. And we don't even have somebody full time that can work on it. Right. And so I feel this every day from a little different perspective because we're just like, wait, how? I just got whatever dropped on us and I still have to do my other job. But now administratively, we have to all do this globally, statewide. Fantastic. But who in my little shop is job it is to get that done? And how am I going to get it done with the time I have? That is where it really falls apart. And so I get why those smaller hospitals become more protective and they're like, feel like people are doing it to them, that they're being told what to do. And they're like, we don't have time, capacity, resources to do that. And so then they're just like, nope, we're not going to participate. And if you come at that from a different conversation about how do you fit in, how could we help you? Because the big groups are the ones who have the resources. So if they want the small ones of us to participate, they should be the ones helping and not the other way around. So it's like, you've got to get the big ones to like, okay, we have the resources to help you. So like, I think about when you worked in the region where you built out that multi-party release of information. You went to the big organization because they had the legal staff to help generate the original and then gave it to the smaller agencies to see if they could live with it. But it was the resources came from the bigger one. And that's why it worked, right? If you'd make the little guy come up with their legal resources to make the release, they just can't. We're pulling something off a chat, out of AI or
But you had to
whatever.
have buy-in from everyone to get there, right? The little ones had to say,
Absolutely.
"We'll accept it," but everyone had to be at the table. You just can't force it down someone's throat
And
and
know
say,
what
"You're
it
going to use
means.
this."
Like,
Right.
because I have this, I did all this work to get this. What does this get me? And
Yep.
if your small group is like, what kind of support do I get because I have that, right? It's like, how can you help me do that?
Right.
Where it's not just, we're going to plug you in so it helps us. It has to be mutual. And that's really hard in this. So it's interesting that in those three hospitals, probably, like you said, they may be in like the same network, hospital network. So
Yeah.
congrats, they're in the same
Yeah.
network. So the three of them figured it out. Ta-da. But the independents are out there going, what?
Yeah. What's going on?
Wow, that's crazy. Anything else you wanted to share about that before we move into
No,
the
that's it.
recovery? That's all you got. All right. So the recovering politician self-care policy week. I'm trying something new. My cortisol levels have been running too high. I'm too stressed out. If you've been following my life, this is not a shock. But I'm trying to do different things to try to bring my stress levels down during the day. So one of the couple of new suggestions I haven't tried in the morning, they've talked to me about drinking hot water in the morning. I don't know why, but it's supposed to be good for you. So I'm going to give it a go. And gentle stretching. So I'm like, okay. Somehow that reduces my stress for the day, and I'm going to give it a go. So I'm going to do it for like a routine for a while. I've got morning routine and nightly routine. See if I can just keep my stress hormones under control to kind of get back into a semblance of order. So, Jason, have you added any more new, weird, or different types of things into your morning or
I'm
evening routine since you
I'm a
travel
big
so much?
advocate of hot water in the morning. I only have coffee in my hot water, Renee.
Well, you're halfway there, I take it. I mean, you're well on your way, so I think you probably got it good. All right, everybody. So today we really talked about the Dakota Conference on Rural Health. We did a little bit more of a deep dive on just conferences in general and some of the things that just aren't quite right when you go to an in-person conference. But we did talk about like those programs that they always highlight at the conferences. And when you ask more questions, sometimes you realize that's really more of a goal or an ambition, not really reality. And that's really hard because it can leave you feeling untrusted and untrustworthy of the person that you were talking to and kind of concerned about are they really telling us the truth about what's going on. And there's a different way to do that. Just tell people it is a pilot, that you're trying it, not that it's a done deal. And sometimes just changing the language makes all the difference. But before we go, please don't forget to follow us on LinkedIn, Facebook, or YouTube. If you leave us a positive review, we send you a prize. Thanks, everybody.